This is a recording of the electrocardiogram, which is recorded constantly during the procedure in case the heart becomes irregular. At this point, the catheter is actually, or tube, is being entered into the arm very carefully with careful protection against infection, and is actually passed up the arm and into the chest and down into the heart. This is a diagram as we just described. You can see the catheter. It is now in the upper chest. It is entering the heart. It is now passing downward into the right auricle or atrium and turning by careful manipulation into the ventricle and up into the pulmonary artery. This is followed under a fluoroscopic control and watched constantly so no problems will occur. This is a pressure tracing which is recorded at all times to determine whether the pressures are normal in the various vessels and chambers of the heart. At this point, the procedure is finished. A bandage is being applied to the child's arm. The data obtained will later be studied. Here's our little patient all through, wide awake, and obviously not much the worse for the procedure. When this data is all analyzed, it will give us an idea of just what is going on in the child's heart.
Did Tommy have this catheterization, Doctor?
Yes, he did.
And how does catheterization help confirm the diagnosis?
As we explained before, pressures are measured on this side of the heart. Samples are taken in various chambers. If there is a hole between the two chambers of the upper heart, as shown before, oxygenated or red blood from this side will appear in this side of the heart. This can be detected on chemical analysis and will show that this is receiving blood from the other side where it should not be.
And how will the surgeon get into the heart to close the hole, Doctor?
This is done by a recently developed technique in which a machine is used called a heart-lung or heart bypass machine, which makes it possible to actually open the heart. This does two things. It makes it possible for the surgeon to actually see the hole and work directly on it, and secondly, to maintain the body's circulation while the heart is not actually working.
This brings us to one of the most important parts of this operation, the heart-lung machine. Dr. Richard Gardner, Assistant Professor of Surgery at the University of California Medical School, has been engaged in research with the heart-lung machine. Dr. Gardner, would you explain to us how these machines work?
Certainly, Bob. Heart-lung machines are machines that have been developed to replace the patient's heart and lungs so that the surgeon may operate on the interior of the heart. I believe that this best can be explained by a simple diagram. Blood is taken from two veins entering the right side of the heart, this vein and this vein. This blood is then diverted into a large chamber known as an artificial lung. Into this chamber, oxygen is continually pumped. The blood, after it enters this chamber, may pass down in the way of a fine film similar to water on glass, and this film is exposed to the oxygen and the blood becomes red or oxygenated by the time it reaches the bottom of the oxygenator. From the bottom of the oxygenator, the blood passes to a pump and this pump is the real heart of the heart-lung machine. The blood is then pumped under pressure back to the patient for circulation throughout the body.
So that you may better understand the machine that you'll see in operation tonight, we made this special film of the heart-lung machine.
This machine is designed to imitate the heart and the lungs. And I want to show you first the lungs. Here there are a number of plastic bags made of polyvinyl chloride, and it is these that provide the surface on which the blood is filmed, much as it is in the normal lung. To do so, the blood must be pumped round and round this these lungs. And for that, we have a pump. Jack, can you switch it on? Here is a pump. By this rotation, blood is brought up these tubes, through here, and into the bags. And then, by wiping the blood across the surface of the bags, the blood is spread in a film. And in this way, a big area is exposed to oxygen. Now, this pump imitates only the right side of the heart, the sort of work that the right side of the heart, the natural right side of the heart does. And now you can see the bag on this side being filled with blood. When it is fully oxygenated, it's taken by a pump over on the far side of the machine and is returned to the arterial side of the patient. We have, of course, in running this machine to measure a number of pressures, and you see here dials and switches. We have also to keep the blood warm, and to do that we have those infrared lamps down there. Here, this particular dial is used for measuring the rate at which the arterial pump is going, and therefore the rate of flow of blood into the patient. And here, this very large dial, I'm afraid, as you see, we can't interrupt the operation, and people will have to pass to and fro. This large dial here is in fact a weighing machine, and with it we can continually weigh all the blood that is in the machine, so that we can keep a very accurate check of it.
Dr. Gardner, what would happen should the heart-lung machine break down?
I know of no instances where this has happened. However, it is tested on animal experiments over and over again before it is used on the human patients. In the event there should be a mechanical failure, all of these heart-lung machines are adapted for hand operation for safety.
We're just about ready to return now to the operating room, but before we do that, I'd like to talk a little about the problems that the surgeon faces in an operation of this type. A man eminently qualified to discuss this is Dr. Benson B. Rowe, Chief of Cardiac Surgery at the University of California School of Medicine, one of the pioneers in heart surgery. What are some of the surgeon's problems, Dr. Rowe?
Bob, this has been a long and arduous fight. The development of cardiac surgery has come about only quite recently, despite many years of hopeful effort in a field which for many years was thought to be impossible. The working within the chest in the first place has only relatively recently been accomplished. Mastering the problems of keeping the lungs expanded while the chest is open, replacing the blood, which is inevitably lost in this kind of work, preventing the infections which may occur by such wide exposures. Then comes the problem of the heart itself. This organ, whose function is the very symbol of life itself, is one that was long taboo to the surgeon. We didn't know how it would behave, what would happen if it were manipulated, whether it would hold sutures being constantly in motion. Then, when we learned from extensive experimentation what the heart would stand, we had to figure out how we could work within the heart. Either we had to manipulate while the heart was working by blind maneuvers during the heart's action. We either had to do that or to suspend the heart's action momentarily while it was entered, and this has been done by cooling the patient, or, as Dr. Melrose has shown you, by substituting the heart's action with a machine. These machines sound simple, but it's extremely complicated to prevent damaging the blood, to keep the blood from clotting, to keep the blood from losing its cells, and to keep it from becoming infected.
Then how is it possible to cut open the heart without killing the patient, Doctor?
Actually, the heart is a lot tougher organ than we at first thought it was. The heart will take quite a beating, in addition to being an organ which beats, and it can be opened, it can be cut and sutured, and it will behave quite well.
How long have operations of this type with the heart-lung machine been performed?
With the heart-lung machine, only in the past 4 or 5 years.
After the heart is exposed, then, Doctor, how will it be opened?
When the heart is exposed, it will be opened over the chamber that, over one of the chambers through which the defect is in existence. In this child, the defect is between the right atrium and the left atrium, which is behind here. And this right atrium, which we can open because of the hinge here, will be opened with an incision, probably right along this line vertically. And when it is opened, not with a flap in the surgical instance, there will be a hole or a defect right in this area, probably, and this can be repaired.
Would you show us on this torso model where the incisions will be made on Tommy?
There are a number of incisions for entering the chest to get at the heart, either an incision across like this, as some of you perhaps have seen, or a side incision over here. Dr. Gerbode will be using what's called a sternal splitting incision, dividing the breastbone, splitting the breastbone right down the middle so as to pull the chest apart. In addition, there will be an incision in Tommy down here in order to get at one of the major arteries to return the blood from the oxygenator, the heart-lung machine, to the circulation.
Now, doctor, to return to the heart for a moment, now that the heart has been exposed and the surgeon has opened the heart and found the hole, how will he proceed to close it?
The hole may be closed by either a direct suture approach, such as this model will demonstrate. Sutures can be placed across, if this were the defect, sutures can be placed across the defect as has been done here, and when these sutures are pulled together, if the tissue is flexible enough and will not tear, they can be pulled together like this and the defect obliterated. Here is a suture which has already been tied. If this defect, however, is too large, or if it is felt to be too dangerous to put tension on the edges of the suture, edges of the defect, then it will be necessary to put some sort of a material to fill this defect, a patch as it were, and we have been using, there are various materials, but this is a sponge, polyvinyl alcohol sponge material, quite similar to the sponge material which you use to wash your dishes. It is compressed, heated and compressed into thin pledgets which hold sutures very well, that the blood cells penetrate and which tissue will resume characteristics of tissue when it's eventually in place. This patch will be cut out to fit exactly the size of the defect as you see here, and then it will be sutured from the heart to the patch, and these sutures tied all the way around the defect.
Will the heart be stopped while the surgeon is closing this hole?
It is possible now to stop the heart deliberately without harming the patient while the heart's function is carried on by the heart-lung machine. In fact, Dr. Melrose was the pioneer in this area, and it is a very important adjunct to this type of work. It is doubtful that Dr. Gerbode will find it necessary to do this with this type of defect, but I am certain that if he feels that it will aid the speed and safety of his approach to the problem surgically, that he won't hesitate to stop the heart on purpose.
How will the surgeon keep track of Tommy's condition during the operation?
Tommy's physiological status, if you will, that is, the condition of his various vital body functions, will be carefully monitored throughout the procedure. This is carried out by expensive, complicated electronic equipment which records these functions separately and puts them on a screen that I think we'll see in a few minutes. Some of these functions, for example, are the brain waves to show that the brain is working and getting enough blood supply and oxygen, the heart rate, the blood pressure, and the body temperature.
We shot some film footage that will show us how the doctor keeps track of Tommy's condition during the operation.
This is one of the multi-channel electronic devices which has several channels on it. You see those spots going across a television-like screen which records that you can see the oscillating line at the top which shows the heart rate, and as you see it has many dials and tubes in it. This is the electrocardiogram, the electrical impulses from the heart to demonstrate what its rate is and how it's behaving.
Thank you, Doctor. Now I see they're ready for us in surgery, but before we do return to surgery, I'd like to remind you that you're witnessing this historical live telecast of open heart surgery from Stanford University Hospital San Francisco over KPIX, Channel 5, presented by Ciba Pharmaceuticals, synonymous with originality and quality the world over. Ciba, where research is the tradition.